Okay, last chapter for lectures for 222. This is chapter 2, chapter 21, too many twos and too many ones in numbers. Anyways, we're going to discuss some neurocognitive disorders. A lot of this is going to be a lot of repetition or stuff that you probably already know because it's basically covering dementia, Alzheimer's, delirium, and those type things. But let's talk a little bit about some base stuff. There's memory. Memory is the ability to recall or reproduce what has been learned and explained. And then there's amnesia, which is loss of recent and remote memory. For neurocognitive disorders in the DSM-5, it identifies several impairments in memory or cognition that represent a clear-cut deterioration from the previous level of functioning. And that's the big thing. In order to be declared a neurocognitive disorder, it has to be clear-cut deterioration from that previous level. You have to have those step downs of those impairments. Delirium is one that is identified. When I say delirium, it is an abrupt, short-term change in mental state resulting from an underlying medical condition. And that's what I want you to understand. Underlying medical condition. Delirium is not long-term. It does not develop over a long period of time. It is abrupt, short, and results from something else. That's delirium. When I talk about dementia, the difference, progressive. If you notice, it's progressive disorder characterized by gradual loss of function. If you remember in delirium, abrupt, short, underlying medical cause, dementia, progressive disorder characterized by gradual loss. It can be classified as mild or major, and terms usually acceptable to younger population when we're talking about mild or major. The most common form of dementia is Alzheimer's. And again, here I want you to notice something. Dementia is the overlying term. It is the umbrella that we talk about. And under dementia lies the different types. And Alzheimer's disease is a type of dementia. That's a clarification that we need to understand. A lot of people just say this is Alzheimer's dementia. Well, that's not it. It's Alzheimer's disease, which is a form of dementia. So make sure you understand that. And Alzheimer's is the most common cause. There's amnesic disorders. In early editions of the DSM, they used to be called amnesic disorders. Now they are called neurocognitive disorders due to other medical conditions. They used to be called, you had amnesia, you had this, you had that. But now they are just grouped under neurocognitive due to other medical conditions. And with that, there are short and long-term memory deficits. Confabulation is the creation of imaginary events to fill memory gaps in individuals with amnesia. So that's when we're talking about amnesic disorders, which are now neurocognitive disorders due to other medical types. To fill in gaps, we would do what we call confabulation. Delirium. Under the biological domains. Remember, we talk about certain domains. There's biological domain, there's cultural, sociocultural, physiological, and spiritual. The way delirium presents in the biological side, the hallmark characteristic is a change in attention and cognitive disturbance that occur acutely and due to some other type of situation. The period develops over a short period of time. It's not aggressive, it's abrupt. Types that normally fall into this: substance abuse, intoxication, medication-induced intoxication, or delirium due to a medical condition. And the easiest one there to associate it with is delirium due to UTIs. Delirium may also be diagnosed as delirium due to multiple etiology. Maybe there's a lot of different things going on. Often occurs in hospitalized adult patients, may be triggered by psychosocial stressors, and it signals an underlying condition that potentially can be reversed. And that's another topic that you need to look for in delirium, or not topic, but another identifying mark, is it's normally 99.9% of the time can be reversed if you find that underlying medical cause. Now, when we're talking about neurocognitive disorder, different than dementia, these are diseases that we have, or issues, head trauma, HIV, Huntington's, Parkinson's. Those are all diseases that present under the dementia neurocognitive disorder. They can affect function in the biological domain. Patients at risk for injuries due to falls, malnutrition, neglect, unable to care for themselves, unable to do, their daily living things. Most common one that we're going to talk about, and the one I want you to focus on, Alzheimer's disease, formerly regarded as senile dementia, but that's not a term that we use anymore. There is a combination of genetic and biological markers. There is also a clear familial pattern. If your grandparents have it, if your dads have it, there's a very good chance that you will get it as well. And they've done some DNA testing and some genetic markers and see that there's 11 clear genes that are implicated. There's a decline in brain functioning due to buildup in plaques and tangles. That's what you will hear in relation to Alzheimer's disease. It is a buildup of plaques and tangles. Pathological theory: beta amyloid protein accumulates, interferes with the spaces in the neurons, and we're going to look at that in a minute. Tau protein standards become tangled, and death or destruction of the neuron. I'm going to show you a picture of that in just a minute. There's a genetic theory, 4 genes responsible for the transmission, and there's also, it's been seen in people with an increase of glutamate consumption. Vascular dementia, again, different than Alzheimer's. It's equivalent to small strokes. It has an abrupt onset. Vascular lesions of the cerebral cortex, subcortical structures from decreased blood supply to the brain. These are the people who have strokes. They end up with what we call vascular dementia. There's a difference between Alzheimer's and vascular. Vascular is due to strokes. Alzheimer's is due to that plaques and tangles. Some other ones that you're going to hear, you don't need to really focus on these, just know that there's different types. There's dementia due to Peyronie's disease. This is a spongiform encephalopathy caused by infectious form of the protein Peyronie. There's Creutzfeldt-Jacobs disease. Adults age 4 to 60, there's altered vision, loss of coordination, a dementia that progresses rapidly. But here's what I want you to see with the normal brain and then an Alzheimer's brain. So the buildup of beta amyloid plaques and tangles, strands of tau protein interfere with the neuronal health, communication, and transport functions, resulting in symptoms of Alzheimer's disease. So here's your amyloid plaques, and here's the neurofibril tangles, so you can see how they're getting in there. So it's a buildup of these plaques that's attaching and a buildup of these tangles that's eventually causing neuronal death. Okay, the psychological domain. In delirium, mental status evaluations reveal rapid changes. Remember, this is very abrupt. This is from, 1 to 2 hours abrupt. There's perceptual differences. They can have illusions. False perceptions of sensory stimuli. They can have hallucinations. Mental status evaluation for dementia will show a slow progressive change, deterioration in intellectual functioning, memory, ability to learn new skills, and ability to solve those problems. Psychological symptoms most discouraging to the family. Normally, this is a disease where I say that it affects the family more than it affects the patient, because the patient is unaware of what's going on when it gets into those later symptoms, and it's the family that typically suffers more than most. And a big thing with dementia is the safety concerns. Are the safety concerns, wondering how this patient can take care of themselves safely at home and maintain, a safe environment. Patients may no longer recognize close family members in advanced dementia, again, which causes that stress in the role taking and the role of caregiver with these families. Individuals may experience depression in the early stages related to the frustration that they know that they're losing ability, so they become depressed. It's difficult to diagnose as patients lose the ability to verbalize feelings, but however, you have to pretty much understand a lot of times they can figure that out. There is paranoia, anger, and frustration because the patient is aware in the early stages that they're losing those small abilities. A hallmark symptom of dementia is in the sociological side is just the loss of connection. It has a negative impact on family and on the family unit. It's a very hard disease on the family. Gradual impairment can affect the relationships. It increasingly discourages lacks of independence, and it creates some conflicts between families. It also has some financial aspects. Access to health care. Patients assist the patients in maximizing resources, finding new resources. Dementia often goes unrecognized and it's not treated adequately until it's to the point to where the patient can't take care of themselves. So we have to be able to see those small changes in our patients when they come for doctor's visits or we see them in the hospital. You can see those small changes and be able to pick up on them. And crucial conversations that needs to be handled dealing with this sociological domain is who's going to help make decisions for this patient. We've got to point out to family members that it's sooner or later they're going to have a healthcare power of attorney. And again, that needs to be done before they advance to the advanced stages and are no longer competent to do that. Culturally, acknowledge and respect the patient's beliefs in their context of their illness. Dementia often poorly is understood in poorer countries. Dementia is a normal part of aging. At some point in time, we will all have some level of dementia. Identifying patient stressors and ability to cope is very important, and watch for those cultural variations of what is a stressful precipitation of patients' copings and comforts. Spiritually, types of grieving similar to those that are cognitively intact, they can go through the same phases and same stages. Nurses need to be fully present with those who are suffering. Individual spiritual journey towards discovering meaning of experience. Both spirituality and religion play a role in health and healing, and we have to understand how it's going to play a role in our families. Address the 6 spiritual areas with these patients. Their value and respect of a person. Celebrate the religious heritage. Embrace simplicity. Seek involvement of persons where possible. Use creative art to support outpourings and provide care through the person's life. We want to make sure we address those areas because there's no cure for dementia. The patient's spirit, sense of personhood can be positively affected by nursing care. And find a way to help patients and family deal, whether it's through prayer or meditation. So, okay, some other key features on delirium. The thing to remember is there is probably a very serious underlying medical condition that we need to find. Because if we can find that medical underlying condition, then we can treat what the cause is and we can reverse this delirium. Delirium causes problems with sleep-wake cycle. The people, they can't sleep well. They have issues with that. They normally have recent memory impairment. Long-term memory impairment is normally not affected with delirium. It's more of a recent. They can have psychomotor retardation as well as very agitated because they know something's not right, and disorganized thinking. It also can affect seriously ill children, and there is such thing as ICU delirium. So there's all kinds of different things that we need to look for. When we're talking about risk factors, there's always risk factors affecting anything, but pre-existing cognitive impairment puts the patient at greater risk. The genetic component puts patients at greater risk. Just an older age if they've had cerebral damage in the past. Certain illnesses and certain medications increase the number of prescribing medications. It increases with the number of prescribing medication the person is taking. Functional impairment and infections all put the patient at greater risk for having some delirium. Dementia leading risk factors for dementia is a leading risk factor for delirium because there's vulnerability of the brain. So if a person has a diagnosed dementia and they come into the hospital, there is a possibility that they can get delirium and take a deviation from their baseline. And that's what we have to gather through assessment and knowledge, is what is this patient's baseline. That way I can figure out if something is going on. Preventing delirium, most effective strategy for reducing frequency and complications. Preventing what can happen. Common preventable adverse events among other adults during hospitalization. We want to try to keep them out of the hospital as much as we can and keep them on such a normal level. With delirium, how does it present? It's a fluctuation in individual state of consciousness. Speech that is rambling, irrelevant, pressured, incoherent. They can have vivid dreams, nightmares, and emotionally instability. And remember, with delirium, these are all abruptly onset. Some autonomic manifestation, things that are going to happen that they can't control, is tachycardic, sweating, dilated pupils, and elevated blood pressure. So these are some things that you can actually lay your hands on and assess this patient for. Slower onset associated with an underlying systemic illness and metabolic imbalances. And delirium normally takes 3 days and sometimes 2 weeks to resolve, depending on what caused it, depending on that underlying cause. Delayed or misdiagnosis can have serious impact on delirium. So again, we want to make sure we know what the baseline is of our patient. That way, if something does happen, we can say, you know, they're just not like they were yesterday. Something has happened, and we can try to pick up on that underlying cause. In dementia, there's multiple cognitive deficits. Disturbance in executive functioning, aphasia, apraxia, agnosia, delirium associated with emotional disturbances, and dementia is associated with apathy. Both delusions, hallucinations, present in dementia and delirium, so you can have that. But emotional responses in individuals with delirium normally involve fear and anxiety. Untreated, unresolved delirium may result in death. And dementia is generally irreversible. We can reverse delirium when we find that underlying cause. Dementia, we cannot. What are we going to do? How are we going to assess? What are some of the things that we're going to look for? Well, first and foremost, we have to do a complete physical and neurological exam. And remember, we have to find that baseline. Where is our patient at? If you have an issue or if you think somebody is having some problems, you want to include a mini mental status exam. You want to assess muscle strength, reflexes, sensory perception, language skills, coordination, laboratory tests, blood and urine samples, x-rays, CT scans. Basically, this patient needs to have a complete overall workup to make sure we understand what is going on with this patient, with these patients at this time. For patients with delirium, we're going to be doing a lot of stuff at one time. We're going to be looking to see if we can find that underlying cause. What's different, what's not. We want to correct that underlying cause, manage the symptoms, supportive care, make sure they're safe. With delirium, reinforcement orientation to time, place, and person at each contact. Each face-to-face contact, we're trying to reorient. Now, a person with dementia, you don't reorient as much. You want to reorient back to their baseline, but we're not trying to cure them. We're not trying to take them above their baseline. With delirium, remember, these people's baseline is normal, so that's where we want to get them back to. Approach them in a tolerant, calm, matter-of-fact approach. Limit the number of choices given to patients with dressing and eating. Identify or clarify reality when hallucinations are present. And promote adequate sensory input. Glasses, hearing aids, room well lit, limited noise. There is such thing as HELP, which is a hospital elder life program. We don't have those in any hospitals around here, but some of the bigger hospitals you do see. It was developed to prevent delirium in older patients, and it's simple actions in different risk areas that are repeated daily. Avoid medication during sleep time, avoid physical restraints, and encourage daily motivation. It's been proven through research that if we get people up, get them moving, not tie them down, not knock them out, encourage that daily motivation, then the delirium risk does seem to decrease at that time. So let's talk about a little bit about Alzheimer's disease in general. Currently, more than 5 million Americans are affected with Alzheimer's disease. The prevalence increases with age. Significant threat to health. There is an increased mortality and morbidity in older adults. And it's acquired intellectual impairment in multiple areas of mental activity. So it affects every aspect of your mental life. With Alzheimer's disease, there's a combination of cognitive deficits and degree to which the deficits impair functioning. So there's a correlation between where they're at cognitively and what it impairs their functioning. So as their cognitive decline decreases, so does their impairment with functioning. Early signs are often confused with normal signs of aging. We see that a lot. Especially because the normal early signs of Alzheimer's disease is just basic forgetfulness. We all get forgetful. So it's often confused, and a lot of times that diagnosis is not made until the patient has moved along into further into the stages, and we'll talk about those in a minute. The National Institute of Aging and Alzheimer's Association published new guidelines for diagnosis in 2011, and it talks about the stages and the biomarkers, and they've all been updated, and we'll look at those in just a second. Hallmark symptoms of Alzheimer's disease, again, is amnesia, aphasia, apraxia, and agnosia. If you don't know what those terms are, you need to review them. I'm not going to just give you the definition of them, but you need to understand what those are. Wandering behaviors. Patient, just kind of wanders aimlessly. There's socially inappropriate behaviors. There's deficits in hygiene, nutrition, and safety. Neuropsychiatric symptoms such as apathy, agitation, aggression, anxiety, and depression are all seen and all hallmark symptoms of Alzheimer's. Another hallmark symptoms is sundowning, and I think you all know what sundowning is. This is the destabilization of cognitive abilities occurring during late afternoon, early evening, and night. It's when the patient basically confuses day and night. Their appropriate environmental stimuli can increase positive behavior, and dementia can decrease patients' tolerance for stress. So they're at more risk becoming stressed out, having issues at basically the drop of a hat. Here's a table just describing the different types of neurocognitive disorders that's under the umbrella of dementia. And you can look down through here: dementia due to HIV, dementia due to traumatic brain injury, dementia due to Parkinson's disease, Huntington disease, and Lewy body dementia. Now there's several different types on there. The ones that you're going to see the most, especially in this area, is dementia to Parkinson's disease, as well as you might see this Lewy body, but again, it's not as prevalent as the most. But the two that you're probably going to see is dementia and Parkinson's disease, as well as Alzheimer's. Okay, let's look at the different stages. Stage 1. This is asymptomatic. What would you think you'd see in asymptomatic? The symptoms are normally so subtle they go undetected. There's not a lot going on here. But however, there are some biomarkers that we can pick up on. And if the patient, has routine healthcare visits and routine visits to their medical care provider, sometimes these biomarkers can be picked up early. But the symptoms, the physical outward symptoms, are normally so subtle they don't go unseen. Because at this stage there's pathological changes already underway. There's beta amyloid accumulation and studies to learn what factors predict transition from mild to mild cognitive impairment. So we've got stuff going on there that we can look and say, these are maybe markers that we can look at and maybe detect an early pattern. Stage 2 is what we consider mild cognitive impairment. This is within about 5 years. About half of those with mild cognitive impairment develop dementia, and most of those develop the Alzheimer's disease. Mild cognitive impairment is an intermediate state between normal forgetfulness that occurs with age and the more pronounced memory and thinking deficits that occur with Alzheimer's. Deterioration in thinking noticed by the patient, the loved ones, and some clinicians. And it's normally an impairment in one or more ability, and the impaired ability to function independently. You start seeing them needing a little bit more attention in memory, language, ability to plan, ability to function independently, less efficient and more slow than before. So those are some of the things that we're going to see in this stage 2. In stage 3, they've named it dementia. Diagnosis probably is made here if the symptoms develop gradually, increased over time, and include 2 of the following domains. 2 of these domains are normally affected: memory, executive functioning, visual spatial ability, language, behavior, and personality. When I'm talking about memory, this is the most common problem area. It typically involves episodic memory. In day-to-day life, this might cause an individual to misplace personal belongings, repeat the same question or conversation over again, forget things, getting lost while walking or driving. Executive functioning basically means the type of thinking includes the planning, reasoning, and judgment. Problem solving also falls into executive functioning. You might see problems here with executive functioning when they can't pay their bills on time, some financial problems, forget doctor's appointments, and those type of things. Inability to organize meals and that type of stuff. Visual spatial ability. This refers to the ability to interpret visual information and see how objects fit into surroundings. Impairments in this ability usually manifestate in many different ways. Inability to find objects such as eating utensils, even though they're in plain view. Then we have impairment in language, and this may manifest in hesitation in speaking or problems coming up with the right words. And then we have behavioral and personality. Uncharacteristic changes in behavior and personality, including agitation, apathy, a lot of mood swings, some obsessive compulsive disorders, and that type of thing. So they have to have issues in 2 of those following domains. And here it is basically in some arrows that kind of showed you. Here's mild dementia, moving on up, moderate dementia, moving on up, severe dementia. So you can see how they increase as they go along. So collaborative care, what are we going to do? With neurocognitive disorders, patients and family have a central role. You have to involve the patients and the family when caring for our loved ones. Community-based care, there's a lot of outpatient settings, day programs, support groups, some psychotherapy can help. Primary care provider, this may not be the best setting for the patient with AD. Sometimes you want to try to find medical personnel, somebody along that lines that can that are well versed in Alzheimer's to help you guide through this process. And doctors that normally specialize in this are called gerontologists or geropsychiatrists. Sometimes advanced practice nurses help with that, but you want to seek someone who deals with it on a daily basis. Support patients and caregivers emotionally, psychologically as well. Remember when I said earlier that Alzheimer's and dementia are harder on families than they are the patient. Some psychopharmacology, only approved therapies. These are cholinesterase inhibitors and N-methyl D-aspartate are the only two approved for treatment of Alzheimer's. And again, this bullet point is very important. No medication to cure. And that's what families tend to think, that if we have Namenda and Aricept and a lot of those medications that are on the market, they're not meant to cure the disease. All they do is slow down the progression. And patients have to be, and families need to be aware of that. Medications prescribed to alleviate symptoms. Sometimes we can use benzodiazepines, antidepressants to address some of those other conditions that come along. With the cholinesterase inhibitors, acetylcholine inactivated by enzymes, it slows the ability, or it slows the degradation of acetylcholine and the patient's improved ability to perform self-care. So this kind of, I can remember we talked about it, slows the progression. It slows the buildup of the plaques and the tangles. You want to monitor for risk of gastrointestinal bleedings, and with these, NSAIDs should be avoided. And these medications basically are your Aricept, your Exelon. Those are the ones that you see in these categories. And there's a chart of the medications on page 485 in your book, so you want to make sure you read over those medications. You have the NMDA receptors. These are your Namendas. They can be standalone symptomatic therapy or combination with the cholinesterase inhibitors. What these medications do is they protect the cells against excess glutamate, and adverse effects of these are headaches, dizziness, constipation, and confusion. Advise patient and caregiver that effectiveness will decrease over time. As the symptoms begin to worsen, then this medication starts to stop working. Change or discontinue in dose is not advised. They normally just leave patient on it. Other prescription OTC medications and supplements, herbal preparations should not be used unless advised by the provider, because there is some drug to drug and drug to food interaction with those. And you always want to keep your monitor and your follow up your appointments. We do use some analytics. Basically the big one used is Ativan. It may be helpful, and again, it's only used for a short time. Drugs with shorter half-life preferred, because we have people here who have their liver not working well, their kidneys not working well, so they can't excrete that medication as well. So we want to use them with that shorter half-life so they can have the clearance. But again, with this, we're only treating those symptoms. Antidepressants, the choice of favor is SSRI, and that's if we see the depressive symptoms in patients. And then we also can use antipsychotics for agitation, aggressive hallucinations, and those type things. And if you notice when I'm going back through these, other than the cholinesterase inhibitors, the NMDA, those are the two that are specific for the neurocognitive disorders. However, the analytics, the antidepressants, and the antipsychotics, and the sedative hypnotic medication, those treat symptoms. And that's what they are. They treat symptoms. The sedative hypnotics are used to help with sleep. Again, you want to be careful with those benzodiazepines and these because there is some adverse drug reactions and they can be addictive. Exercise is another good thing. Keeping the mind active. That's another treatment that we encourage patients to do. It has the largest effect on that executive functioning, the planning, the coordinating, the working memory, that type of thing. The more we use the brain, the more it stays active. The less we use the brain, then it starts to atrophy and it starts to die. So we have to keep that brain active. Reality orientation. You have to be careful with reality orientation. Sometimes it works, but however, sometimes it also causes increased agitation and issues. So we have to be careful with that. Conversational aids designed to help orient the patient. You want to keep it simple and focused. It depends on the patient's abilities. You can use props such as books, clocks, calendars, orientation boards, anything to help that patient kind of tune into reality. However, in use with these, if you see it increasing the patient's agitation, then you definitely don't want to continue to use it. You want to try to maybe take another avenue. Validation therapy. This works for people who can't do the reality orientation. Searching for an emotion, meaning behind the patient's disoriented words or behaviors. Kind of have to play detective there a little bit. Like for a patient walking down the hallway asking the staff, have they seen your mother? Say, tell me about your mother. What does she look like? And this is, for a lack of a better term in layman's terms, this is just kind of going along with the flow. You kind of, if the people aren't responsive to reality orientation, then just validate what they say and go along. That keeps that agitation down. Reminiscent therapy. It's a process of reflection involving remembering or thinking about the past. They do this in the nursing home a lot. Patients with AD retain long-term memory in the earlier stages, so we want to use that as much as we possibly can, because using those memories helps promote self-esteem, identity, and it decreases isolation and withdrawal. Art therapy, complementary and alternative therapies. Any medium can be used. It promotes well-being in people with AD and staff member satisfaction in increasing the patient's individualized interventions with a trained therapist. And again, these are for people who are in those early stages, not necessarily in the later stages. However, music therapy can be used in the later stages. There is evidence-based practices to support music therapy. Use of music decreases agitation, aggression, depression, and agitation. It's used as a distractor. It can decrease the need for chemical and physical restraints and also can improve cognitive functioning. That's why in a lot of rooms in the nursing home, you'll see radios and that type of thing. So now that's treatment. So what are we going to look for? I mean, how do you assess somebody with dementia? How do you say if this is dementia or how do you say this is delirium? Big thing, history, physical, diagnostic studies. You want to make sure that you look at everything. Mini mental status exam is a good one. There's a functional or a maximum score of 18 or maximum score of 30. Usually if they score 18 or higher and they're in early stages, lower than 12 normally means they are in the lower stages. And you want to do that on a continual basis because you want to keep up with where they're at. Kind of chart that. So diagnosing and planning, fear, anxiety, most common of all nursing diagnosis in delirium and dementia, may be related to illusions, delusions, and hallucinations. Other common diagnoses you see here. And again, with these diagnoses, remember, this is just normal ones. They're all dependent on your patient's care and symptoms that they present with. Some more common diagnosis you see here: nutrition, memory, communication, helplessness. Again, you got to address what's wrong with your patient. When we're diagnosing and planning, we're going to incorporate those 5 domains. We want to make sure that we cover the physiological, the social, the cultural, the spiritual when we're looking at what are we going to do for this patient. Consider whether the patient's capable of collaborating in palliative care and to what degree. and consider the most distressing symptom for both patient and family as the immediate thing that we want to fix. We want to get that distress out of the way. Big thing with Alzheimer's and neurocognitive disorders is promoting safety. Good way to do that is assign patient to a room close to the nurse's station so you can keep an eye on them. Provide a room with low level of stimuli. Provide a well-lit environment. Have patient wear identification bracelet and use monitors and bed alarms. Administer medication PRN for agitation and anxiety. There's just a few. Depending on your patient, what's going on, that's the safety that you're going to choose. And remember, when you're taking tests, hint, hint, safety on the psych side is normally paramount. You want to promote orientation to time and space. Some ways we can do that is orientate at different times differently during the day. Range from mild to severe. Patients may miss occasional appointments or confuse day and night, so you want to make sure you orientate them. Provide compensatory memory aids. Maybe it's stickers, maybe it's a med pill that beeps, whatever it may be. You want to promote that orientation to time and space, and keeping their routine daily. Constant daily is really important. When you start messing with their routine, it starts messing with their abilities to stay focused. You want to promote self-care, and we do that by having the patient perform self-care to their ability every time. You just don't want to come in, take over, and do it all. The patient needs to be aware of for needs of ADLs and perform tasks based on that patient's condition and giving them step-by-step instructions. We want to promote communication when we're doing interventions and implementation. Deficits in receptive and expressive language, we need to address those. How do we communicate with this patient? What are the things that are seen? Responsibility to facilitate communication lies with the nurse, doesn't lie with the patient. So you need to make sure that you can interpret the meanings of behaviors rather than dismissing them as simply a symptom of dementia. You need to make sure that you understand what your patient's thinking and feeling. Use a reassuring tone. We don't go in with an all big, demanding, nasty, argumentative tone. We want to keep it soft and reassuring. Reinforce reality and orientation when needed. Don't argue about it though. If they have a question delusion, use validation and distraction, because you don't want to upset them even more than what they are. Encourage reminiscing about happy times. Minimize need for decision making. Break activities into short time frames. And again, along with all this is probably one of the biggest diseases that you're going to treat the family just as much as you treat the patient with the disease, because we have to provide support for the family. Because caregiver burden falls on that family. It's high emotional stress. They're often untrained and have very little knowledge about the disease, as well as anxiety and depression normally run high. Treat families about disease and specific interventions. What can they do to help what this disease is? Provide education related to medication safety, especially in relation to patients living in the home. Baby monitors, intercom systems, bells, install handrails, remove clutter, throw rugs. Whatever it takes to make that home safe is what we want to do, whatever it may be. Know the resources that are available and provide referrals if needed. Remember, patients suffering from dementia or delirium, you don't want them to lose hope. Family members also experience hopelessness, so we want to be as supportive as possible. Supportive care reduces the level of frustration and it lifts the mood. Helping family members negotiate caregiver duties and reduce interfamily conflict also helps them move from that suffering to hope. Empowering patients' independence for as long as possible. Honor the person for who she is or who they were. Assess the patients carefully for underlying cause of the disorder. Listen and observe for interventions that improve health and awareness, and just take time with patients and their families to instill trust and hope in them. And that's the best thing that we can do, is spending time and understanding, helping the family and the patient understand what's going on.